Hello friends, I am Dr. Bharat Modi from Wellcare Hospital, Vadodara. I have spent what I would think is almost an entire lifetime working in the area of total knee arthroplasty and arthroplasty at large, but certainly much more focused on the total knee arthroplasty. And on request of my fellows and students, I have decided to come up with a series of lectures which will take you through what I would consider as a primer and as an overview of understanding the science and art of arthroplasty.
Good morning, gentlemen. So, in this series of lectures on knee arthroplasty, we have reached the stage wherein we discussed in considerable detail all the tiny nuances that go into making your proximal tibial cut. We realized that although it looks to be a simple action, just chop off the top of tibia, it could be interpreted as simply as that, and yet it took us a better part of almost 45 minutes of last lecture wherein we understood how many things go into making that cut as far as the surgeon's brain processing is concerned of the situation on the ground. Essentially, the two things that we need to keep in mind is the angle at which the proximal tibial cut is made, and that includes whether you are a mechanical aligner or a kinematic aligner. It could be at 90 degrees to the mechanical long axis of the tibia, which means that you ignore the anatomical orientation of the tibial shaft. In other words, if there is some curvature in the tibial shaft, you don't go by that, you go by the mechanical alignment, which is an imaginary line from the top of the tibia to the bottom of the tibia. Yeah. So 90 degrees with some posterior slope. You are looking at the lateral side here. So some posterior slope. And that is how the vast majority of knee replacements happen even today, because the vast majority of surgeons across the world still subscribe to the mechanical alignment approach. All right. So we did our incisions, we did our exposures, we brought the tibia subluxated or dislocated from underneath the femur, and we have taken our proximal tibial cut. Today our lecture will cover the cuts that are relevant to the femur side of the entire equation. So we will start off from here, and as you can see, now the tibia is cut. This cut surface gives you a reference point for the further cuts that you will make on the femur, and all the time you have to understand the aim of knee replacement in its very basic simplistic terms is to create a rectangular block in extension and in flexion which are equal. This is the long and short of knee replacement. Then you can add layers of complexity. Will my rectangular gap be oriented like this? Should it be oriented like that? Should it be oriented like that? Should it be oriented like this? And the combination of all this. And then similarly, as you go into flexion, will that rectangular gap remain like this? Would it go into a bit of this tilt or that tilt? All those complexities are added as you go along the path of examining this entire approach. But the underlying essence, if you have to bring out in one statement, it would be create well balanced equal rectangular gap in extension and at 90 degrees of flexion and all throughout that range of movement. This is the long and short of knee replacement. All right. So you have taken one of the cuts, and remember this cut will participate in extension when you straighten that leg out, and also in flexion when you put it into 90 degrees. So this tibial cut is participating in the formation of the flexion gap and also in the extension gap. How do we start with the femoral cuts? So unlike in the tibia, where traditionally when you are using the conventional instrumentation set, although some of the instrumentation sets will provide you an intramedullary rod from where you take the tibial cut, in reality hardly any surgeon will do it unless it is a revision surgery. Then he might use an intramedullary for reasons we'll talk about later. But the vast majority will use an extramedullary jig, and we discussed about how that jig has to be adjusted in all these different planes, to get your cut as you want it. In the femur side, unlike on the tibia side, the cuts are taken from an intramedullary jig. So first you will create a hole here from where you will put in your intramedullary rod, and on top of that rod will come the various blocks which will help you guide the distal femoral cut that you will make. So first of all, the most common question I am asked is, how do we decide whether you take the intramedullary entry point here or here or here? It's not actually you don't have to be as finicky as 2 millimeter here or 1.5 millimeter there. I told you earlier, early in the morning today, Asha and I were discussing again things about anatomy and what is the difference when you become a surgeon in theatre and when you are a resident preparing for an exam. When you are preparing for an exam, you yet have not had the opportunity to independently go to the human body and start putting the knife to skin. So most of the time you will conceptualize an anatomy based on the reading in the textbook. Most of the time you will focus, your brain will focus on descriptive terms like 3 millimeter in front. Now when someone is trying to convey some message to you without he being there, obviously he has to write something, so he has chosen based on anatomical studies, let's say 3 millimeter. But if that same person was there in the theatre, like here, no, go back, like here, all I have to say is, I don't have to give you if you ask me where do I put my entry hole, and I will say put it here. But if I was not here and this was not there, I will have to use something. So I will say about 3 millimeter from the margin of the intercondylar notch. And then this 3 millimeter sticks in your brain as a young impressionable student resident mind. And you will end up becoming fixated on, but no, it's this is 3 millimeter, but then this looks like 5 millimeter. The point I am trying to convey by this long description of this action that I see again and again in young minds who are starting off is, you end up confusing yourself and it's a waste of time. All you have to do is ask your common sense, what am I trying to achieve here? I am trying to achieve that my intramedullary rod goes into the intramedullary canal. That's all you are trying to achieve here. So if you take it here or a little bit here, as long as you are not going outside the anterior and posterior cortices of your medullary shaft, like so, as long as it's not so anterior that you are going to go out, or it is not so angulated that you are going to penetrate it back. Yes?
So irrespective of the direction of the intramedullary jig and irrespective of the entry point, as long as the intramedullary jig is inside the canal, the entry point won't matter, right?
Good question. So now go to the next diagrammatic representation. See here. He has taken it so that the entry point, once you put your rod in there, it will allow the rod to not hit this or that. And this is a visual judgment on the table. When you are choosing this from this side, because this is a lateral photograph, taken from the lateral side. But if you are looking at it from the front end on, if you have cleared your intercondylar notch properly of the soft tissue attachments, which means the ACL and the PCL, if you are going to do a PCL sacrificing knee, then you will be able to see the posterior cortex of your medullary shaft here, and the anterior you are already seeing by virtue of having cleaned up the suprapatellar pouch, etc. So the human brain is able to process like this, that okay, this is my anterior, this is my posterior. If I put my drill hole here, it's going to be in the middle. Now go back one, see what is being shown here. He is putting the drill here, only a little bit, not pushing it right in, and rotating it. These two light colored things, what they are trying to tell you is open up the mouth a little bit wider, so that it is not the mouth which will dictate the direction of the rod as that real rod is pushed in, the actual intramedullary rod is pushed in. This is exactly the same thing which I explained to you day for yesterday when you are doing your first core decompression, that when you are putting a guide wire from the lateral cortex for something like a core decompression, wisdom is in actually opening up a larger window on the lateral cortex and then putting a thinner wire so that it easily allows you to choose or modulate your direction of the progress of the guide wire inside. If it is a very tight fit like this, if your lateral cortex, whether it be the guide wire or in this case the drill bit, femoral drill bit, if you have drilled the femoral drill bit in and it is exactly the same dimension, the hole is exactly the same dimension as the femoral drill bit itself, now it is this which will force my further progress of my drill or a rod or whatever guide wire. But if I have in the early stages done a toggle like this and made it a bit larger, little bit larger, now I have the ability to modulate my progress of my instrument as it inserts itself further. So this is a small but very important aspect, not only for to answer your question, that once you have done that and then when you push your intramedullary rod in, now the cortices will make sure that it goes in between the two cortices, and when you push it long enough and deep enough inside, then it will automatically catch the anatomical orientation of the medullary shaft, of the shaft of the femur. So again, if you push your intramedullary rod only up to here, then it has the potential of giving you wrong readings on your cutting block. But once you have put it right up to here, then now the rod is captured well enough by the shaft of the femur to truly represent the anatomical orientation of the shaft of the femur. Are you clear? Number two, besides this important mechanical aspect of this action, the other important thing that it offers you is that a larger mouth, which now has some space around after your rod, allows the fat to migrate out, so that you do not create fat embolism by pushing a rod in a space where there is no further space. And now the only way the rod can make a way for itself is push the material which is already in there aside, and that material is marrow fat, and that marrow fat, when you are pushing it aside, it might go into the vasculature and cause fat embolism. You require only a few ml of liquefied fat to enter your circulation to trigger off what is known as the phenomenon of fat embolism. Fat embolism is not necessarily just a mechanical obstruction, it triggers off a metabolic disturbance which then cascades itself. And how important is this? You will be able to judge when even in the initial, not even this, in our operation theatre we will normally use a 3.2 drill bit to create the first small impression on the, go back would you please once. So before you put this, you take this femoral drill which comes with the instrumentation set, you use a 3.2 drill bit. Even when you put that minor 3.2 drill bit in, and if you are a keen observer, if your brain is alerted to whatever is happening around you, then you will see some blood being pushed out from the anterior cortex of the femur. Even at 3.2 drill bit in a massive medullary canal like this, which is a voluminous thing, just imagine what is the pressure that would be generated when a rod enters the isthmus area. And that is why in our theatre it is a inviolable rule that once you open up the mouth, next please. Once you open up the mouth of this canal, before you introduce this rod, you will put in a suction catheter, a flexible suction catheter right up to here, and keep on sucking till you start getting red marrow fat, not yellow. There will be yellow here and red here. So if you have been seeing only yellow fat, bone marrow fat coming into your suction tube, do not kid yourself that you have evacuated the shaft. It is only when you start seeing red that the shaft would have been reached. And many times the trabeculae here are so strong that your catheter will not progress further, and in frustration you might just give up. Do not do that. Use a tiny thin probe like thing in the form of a spoon or something to put it in and break the trabecular obstructions, and then put your soft catheter in. If required, do it twice. If your soft catheter gets blocked by bone debris or marrow, there is always a second catheter on the table so that the surgeon doesn't get tempted कि अब चलने हो गया है, you know. No, be absolutely fastidious about this fact that you have evacuated all the red marrow. I learned the importance of this early in my career when a well done knee replacement, and I remember the name of that patient, Geeta Ben Karinata Desai. And Geeta Desai, I still remember the face of that woman. She had a very thick myopic vision, so she had the glasses, colloquially we say, the bottom of a bottle type glasses, etc. And I had 3 beds under my command in a tiny little space which was this much, the office that you are seeing. That was my entire ward area of my place, And so she was in that one corner and there were 2 beds here. And my entire team consisted of 3 people. And I, after a good execution of a TKR done, I went home. I couldn't, in those days, I'm talking 25 years back, I couldn't afford medical officers. In fact, most people like me, they themselves were the medical officers or the janitor, whatever the role was required. We used to play that role ourselves, And I went home, and there was one thing that woman had complained of in that, and I'm digressing here, but listen to these stories. It is these stories which make you what you are on a definitive basis. So there is one thing that had happened, and as I was going, she was talking, she had already had her coffee, everything. This is 4 hours after the surgery was over, 4 to 5 hours. But there was one thing which she said, okay, sir, she was perspiring to the point where I could see that her hospital gown was wet, and she was perspiring. But otherwise she was not complaining of anything at that moment. And I thought maybe it is the heat of the room and the day, and I went home. Roughly about 3 hours later, my nurse calls me and says, sir, she said, yeah, the systolic pressure of this patient is, what did she say? She said it was some, the diastolic pressure, yes. What she said was, okay, sir, I can hear the diastolic pressure, which means she was referring to the Korotkov sound. She said, I can hear the diastolic pressure, but I am not able to hear the systolic pressure. Exactly. So that furrowing of your brow tells it all. I said, that's not possible. You cannot come to a diastolic pressure reading until you have started noting the systolic. She says, no, sir, it is like that. Actually, what she was meaning is that her blood pressure, this woman's blood pressure had dropped to some 60 or 70, and in her own simplistic common sense way कि 60-70 का भी systolic हो सकता है क्या, वो तो diastolic का reading का level है. Anyway, I came to understand what she was talking. Then as soon as I came, I saw that the woman was now having breathing difficulties and she was cyanotic. And actually what had happened was that the fat embolism had taken root. It had triggered off that process. ARDS had already been established in her lungs, and I lost that patient. And yes, and in my career I have lost patients to fat embolism like this twice. And the other patient was one Mr. Thakkar from Anand. Again, I remember this case vividly. It is printed in my mind just now as if a movie is going on. And this patient had so much faith in me because I had replaced both his knees, eventually both hips. One hip I had already replaced, this was the second hip he had come for. And I was using a particular system. It has nothing to do with the company's name, so I will not use the company's name in this lecture. But what that company offered as part of their instrumentation was, these days you see those RASP for femoral canal ingress. Yeah. After you do your neck osteotomy, and when I was using the rasp, to start off the rasping process, they had a cylindrical blunt bullet-like reamer, which they would do it as a starting point before you started the rasp. I remember that moment. I remember because it is in retrospect that I understood the importance of this. That when I had done that cylindrical reamer, it's a bluntish type of a reamer, because you are going in cancellous bone. I saw fat oozing out of the periphery of that, the blood and fat. This is your cut surface. When we are pushing it from here, I could see that. It registered in my mind that I saw that, but it didn't register in my mind what it meant. And later on, again, the history of fat embolism folded, classic ARDS, classic. Over the next 48 hours, he kept on developing, irrespective of whatever we did. And that's the point. That's when I read up on fat embolism as an entire phenomenon. So even in those days, young man, I was a loner in the sense there was hardly anyone with me. I the surgeon, and I the janitor, and whatever 10-15 people I had with me, But I had this drive in me. If something wrong happened, my mind will not be emptied of that. Even today it is not emptied. So I would go to the books, I read up on it, I talked to whatever colleagues might be able to contribute, but I read up and then prepared a short note on it and gave it to all my nursing staff, etc., in the vernacular language, etc. Okay, next time if you see something like this, be alerted that this is in fact, I have given all that up as I progressed. The irony of my life's journey is that I was far more capable of doing a very methodical job when I was working with a 10-member team with 3 beds, than what I am doing now with such a large establishment. And this is the history of most organizations. It's only when the next generation is ignited into something like this, then maybe an organization can sustain the same thing which the original founder was capable of doing, or that is why it happened. That organization happened because the original founder had that type of a mad zeal. So coming back to this, so they do not underestimate the importance of evacuating the fat from that medullary canal, and this applies to the femur side in hip replacement, which again, as Vipin, you guys know.
So if during your case or right after your case you do suspect that this patient might suffer a consequence of fat embolism, what are the preemptive steps that you can take to prevent it before it becomes worse?
Very good question. So what happens in fat embolism? Or in for that matter, in so many different processes like DIC and all that, even in fact, the final trigger point is multi-organ failure. The multi-organ failure is a common endpoint of many pathological processes. Multi-organ failure is triggered by hypoxic status of your body systems beyond a particular period of time. And then it becomes irreversible or very difficult, or at least to the extent that I would know, because I am not an intensivist. I only know enough to then try and prevent it, or then recognize it if it has already happened and then give it on to the intensivist, because I have not gone into that level of detail. So in a multi-organ failure where it is hypoxia which is causing the push towards the multi-organ failure, what you can do is, and that's why I told that girl that next time around, if you see the slightest of bluishness or a patient perspiring, that's the first thing that happens. If a patient says, in Gujarati this word ghabraman, which means a sense of uneasiness and profuse sweating, and the patient and the relatives themselves many times will explain it away, and the uninitiated, whether it be a consultant surgeon or a nurse or whosoever, they will think, हाँ ये तो बराबर है, गर्मी है आजकल ना, and they will say कि हाँ इनको तो ऐसे भी बहुत गर्मी लगती है, घर पे भी वो हमेशा गर्मी में की कंप्लेन करते हैं, and it will lull you into a false sense of security. In a patient on your bed, whether pre-operative, post-operative, if during your round or if anyone notices, especially if you have sensitized them, So when you are taking your rounds, or find those 5 minutes to quickly have a chat with your nursing staff and medical officers, etc. Just after a round, just stand like that. Okay, just one question for today's round. How many of you know the importance of a patient saying that बहुत घबराहट થાય છે, बहुत गर्मी થાય છે, बहुत पसीना हो रहा है? Just ये एक चीज़, and then give a small story about what it means. So hypoxic status leads to this. Now your question was specifically what would you do to try and combat this? I think the first thing that I would do is recognize and then start oxygenation, put them on monitoring, and then call in the intensivist as far as anything of this nature is concerned. Because ARDS, adult respiratory distress syndrome, is again an endpoint of a few different pathological processes, and to the extent that I know, you have to then migrate that patient to artificial ventilation, and it can last for days and days, and then it seems those who are lucky, those patients who are lucky, the process can get aborted at some point, and then the lungs start getting clear, and otherwise in those who are unlucky, the lungs keep on getting stiffer and stiffer by virtue of whatever is happening there, and they die because the lungs do not recover from that, irrespective of the artificial ventilation being pushing air inside. Yeah.
So for pulmonary embolism, we can first initial step we can give
at the mainstay, जो कोविड में भी हो रहा था, but कोविड में clotting के हिसाब से हो रहा था. So that's the point I'm making. But I would be out of my depth to take that level of treatment on my hands. That's why I'm stopping at the point where I'm saying, yeah.
And in today's day and age, considering that we live in a litigious society, so to speak, and we have to justify every action as a doctor that we end up taking, is there an investigation of choice, like a CT pulmonary or something that we should get done before we move the patient to a higher center and upgrade treatment?
You could do so, but my advice to you would be that looking purely from even a litigious society point of view, the moment you involve an intensivist and you are taking appropriate action, and that itself is the most appropriate action, that once you recognize, you immediately involve people of a more expertise level in that area of work. Purely from a medical legal point of view, in a court of law, if you have documented all this, you would be well protected. Because what does a medical legal criminal medical negligence, how is it defined? In a very simple set of words, I would say that if you have been negligent in not offering your patient the accepted standard of care in those circumstances. In a village, if this is happening, the physician or the doctor or a GP might be one of those unique geniuses who knows all this because of the sheer force of his interest in the, but he cannot do anything beyond it. There is no intensivist, there is no ventilator. Then he will be judged on whatever you did, similarly.
Just to enforce the point Dr. Rao said, that every minute counts in the OT. So before we call the intensivist, and if he is not around, like Dr. Vipin said, is very important to start oxygenation and IV fluids. And anticoagulants are equally important to start before the intensivist arrives. And I feel we should know the dose, how much to give.
Take your point on board that even if we don't think of ourselves as experts in treating ARDS, what Asha is saying is that in the modern day context, in a city like Vadodara, on a platform like WellCare, if as orthopedic surgeons you are able to recognize and trigger off the two basic things which are not going to damage your patient as far as the life is concerned, if anything it will only help, and which is anticoagulation and steroids, then you should do it. So you should know what dosage, etc., and at the same time trigger off getting a intensivist on board. Fair enough, point taken. And having taken this point on, hopefully in the next lecture, when I ask you what are the dosages involved, each one of you will just roll it off in unison. Yeah, good. So here we come so femur, go back one. So now you have done the drill hole and you have pushed your intramedullary rod in. Once you push it in, you remove this T handle. Okay.
Sir, one question. Some people, some surgeons say that if we dilute the femoral canal with 100 ml or 150 ml NS, that is sufficient to suck out the fat and it reduces the chances of fat embolism. It is enough or it is proven or sufficient? What's your opinion, sir?
They say good luck to them, but I think rather than diluting, evacuating it is far more, common sense. There is dirt here, I can put water in it and just allow it to flow around, and then there is another way, I can just vacuum it out. So I prefer to vacuum it out. So I wouldn't, in fact, you know what, if I have to be really now pugilistic, if you trigger my debating instinct, then I will say that diluting it means you are reducing the viscosity, means now if you pressure it, it's easier for it to migrate into any small openings, So it's, in my opinion, vacuuming it out is much better. Next please. So now on top of that rod, that was the rod from where the T handle has been removed, and now you put what is called the femoral locating device. Basically these are a couple of set of metal pieces of equipment which you put on this rod, and now on that, first and foremost, these are unfortunately inverted images. So you have two things. One is the medial and lateral profile of the condyles, which you sort of use as a reference point to look at the rotation, and ideally you should be having once again, your distal femoral cut is not all that important as far as this rotation is concerned, because it's going to be at 90 degrees. We discussed this issue on the proximal tibial cut. If your proximal tibial cut was going to be exactly at 90 and flat with no posterior slope, then it doesn't matter rotation, because it's going to be exactly the same from whichever side you cut it or so. Here there is no slope on the distal femur unless you choose to do it as an intentional matter, but otherwise there is no scope of any, and I am using that word unless you choose to do it because there are, when you go into the nuances of discussions of functional alignments, etc. And now you are talking about incorporating a tilt in the sagittal plane as well, but clean your mind of that micro crap and we will talk about it later. So at the moment, if it is a 90-degree cut, this rotation in itself is of no significance as far as the distal cut is concerned. Anterior and posterior cuts, of course, extremely important, because now that is what will decide the rotation of your femoral component seating. But this is at the moment not important. But your brain needs to start orienting itself about the rotation aspect from this step onwards. So this is what helps you, the profiling of, and typically you should look at the medial side condyle looking a bit more than lateral as a general rule. Once in a while you might have so much of medial condylar bone loss that it might not be true, but as a general rule. More importantly, it is this figure that is important. These are the mathematical numerics that you see here, right and left. If you are using the or replacing the left knee, then you should be focused on the L, the left side of it. And those figures are the figures which decide the distal valgus angulation that you will give to your distal cut of to the femur in relationship to the anatomical axis. Okay. Go to the next. Let's see if there is a here we go. Yes, beautiful. So as you can see here, this is the figure which will help you get this concept in your visually in your brain. Look at the rod. This represents the anatomical axis. This represents the anatomical axis, whereas this represents the mechanical axis. And because the femur comes like this, like so, and the mechanical axis you want is like this, the angle between the anatomical axis, this is the anatomical axis, and the mechanical axis, that angle is the angle which you have to decide, that at what angle. So again I am starting from here. This is my anatomical axis like so, but I want my knee joint components to be oriented in such a way that my joint line is at 90 degrees to the mechanical axis. So if I was only using my anatomical axis, see here, and if I am going to do a 90-degree cut to the distal femur 90 degrees to the anatomical axis, then the bone cut would be oriented like this. my mechanical axis is coming from here. So whilst my bone cut is oriented at 90 to the anatomical, it is not oriented at 90 to my mechanical axis. But the entire mechanical axis philosophy is about having the cut at 90 degrees to the mechanical, not to the anatomical. So you are, remember something, in this methodology, unlike navigation, here you are referencing your distal femoral cut from the anatomical axis. So all the actions that you are taking is in the background. This knowledge has to be clear in your mind. Most of the time, vast majority of surgeons, they do not get this explanation in their formative years. So they just have a mechanical superficial level thing, ये करके इसको वो 5 पे रखना है और ये करके, but क्यों 5 पे रखना है, why 5, why 6, what might be the systematic way? And even if you don't, as a having understood, you might decide कि मैं हर बार 5 रखूँगा, but at least you should be aware कि क्यों आप 90 डिग्री मैकेनिकल को रखना चाहते हो. तो आपका एनाटमी इधर है, आपका इंट्रामेडुलरी रॉड आपने एनाटॉमिकल एक्सिस में डाला है, और जो कटिंग ब्लॉक जो है, आपका कटिंग गाइड जो है, उसको अभी आप ऐसे घुमाना है कि इफ़ इट वाज एज सिंपल एज 90 टू द एनाटॉमिकल एक्सिस, तो बहुत सिंपल है यार. आपने वो रॉड के ऊपर 90 डिग्री में ऐसा है वो ब्लॉक बिठा दिया और उस पर से कट कर दिया, तो दैट कट विल बी एट 90 डिग्री टू द एनाटॉमिकल. बट नो, यू वांट इट 90 टू द मैकेनिकल. तो ये जो मैकेनिकल तो यहाँ से जा रही है, तो यू वांट इट लाइक दिस. तो वो जो करना है, that way, if you want to do it as a precise calculation, get a scanogram and then draw the lines, and whatever angle comes here is the angle you have to put on that correction part here. तो ये जो है वो ऐसे गया, if it was even more then ऐसे गया, कम है तो ऐसे गया. समझ में आया?
Although if on a scanogram while templating in during my preoperative planning, if the angle at the mechanical axis and the anatomical axis form is, let's say, 9 degrees, I don't think I would have the courage to then take a 9-degree valgus cut on table. Right? So how do you go about that? Do you come back to 5 degrees to be safe?
Perfect. What a good question. And I think we debated and discussed this when we discussed earlier, whether as part of this forum or at home or somewhere, when we were talking about, and Arun Mullaji has written a good paper on this, that especially in the Indian women, the femoral bow is so severe that the anatomical, exactly what you are saying, the anatomical deviation can be dramatic. 11 degrees, let aside 9. He has documented 11 and 13 in some cases. So do you really do all that much just to get your mechanical alignment perfectly right? I personally would not, because that would probably invade the lateral femoral condyle cut so high up. He has done it in some cases and showed it, that later on post-operative scanograms look perfect, although the component might look a bit weird on the lower end of the femur from what you are usually accepting it as a visual image, in the usual circumstance. But Arun in his lectures has shown it, that with a navigation, so that he was 100% confident that what he was doing was right. So again, a quick understanding now that you have focused. What this rod insertion represents is you establishing anatomical axis and then doing your cuts by back calculating it for the mechanical axis. And the fundamental difference between this and the navigation, robotics is just one more machine cut just to do that. Robotics is 90% navigation, 10% a little bit extra. So what the navigation allows you to do is, because it has this third eye which humans don't, so it can actually see the mechanical, into inverted commas, see the mechanical axis, and therefore it can take its judgment based on the mechanical. It doesn't need an intramedullary rod. The system of instruments that are designed with the help of navigation is that navigation, as if you want to call it as a surgeon, navigation as a surgeon he or she can see the center of the head of the femur, center of the knee and the ankle, and then having seen it, it will very quickly, without having the need now to work from the anatomical axis, it can just say कि नहीं ऐसे रखना तो आपका कट 90 आ जाएगा मैकेनिकल को, समझे?
Having understood the concept, just to have a better understanding of the orthopedic technology, when you say you have to take a valgus cut, what exactly does it mean in reality?
So superb. So I hope you remember we had this incredible discussion on this. This is very important. This is one of the most valuable lessons you will take away from Bharat Modi and your time at Wellcare. The word valgus and varus has become so confusing because it is used with the general idea that whenever we are talking valgus, it is like things going out like this. And whenever we are talking varus, it is things coming in like this, general. So this was one aspect. The other was over a period of years and decades actually, until Johan Bellemans and Sam McDessie very clearly brought out what is now known as the CPAC classification. What is CPAC as a concept? CPAC is that they brought it to our notice, which intuitively our brains were often not understanding but encountering. So we were getting confused. कि भाई यार ये the limb is in varus, obviously this is varus deformity, but table पे या X-ray में the joint line is looking as if it is in valgus. Now if only we had maybe when we come to the CPAC, I don't know, disrupt it here, but still. So historically, the fraternity and the textbooks have used the word this when I put it, when I take a cut, Sutya, when I take a cut which is going to put my leg from here into this direction, which means valgus, you will say this is a valgus cut, valgus cut. That is why you use the word 6 degrees of valgus angle. Ideally, now that the CPAC classification is brought in and people understand, we should dissociate the two things. The orientation of the joint line, which up to now was being, the word was being used as valgus if it went like this, neutral and varus, on the grounds that any cut like this will get my tibia or leg inside, any cut like this will get it straight, and any cut like this will get it into valgus. However, in a varus orientation of the limb as a whole, in the various orientation of the limb as a whole, remember now what I am saying. You have a leg which is going like this. You took a, let's say 5 degree cut.
Open up the CPAC classification diagram.
I know, but just focus. This is extremely important. It's here that it really matters. Now you have a leg which is going like this. You are taking a cut which is going to bring the leg from here to neutral. But because the movement is in this direction, the orientation of the cut that is happening here, you end up using the word valgus cut. Although end of the day, when you have finished your work, you will see the limb in neutral, and for all you know, your joint line will also be at exactly 90 degree, which means neutral. So once the entire thing is over, you had no business using the word valgus in a true sense, because valgus means going outside from that middle line. This confusion about the nomenclature, about the usage of words, what is known as semantics, because it is never been dissected out for the young mind, they get completely confused during conferences, during talks with each other, during hearing the senior people, and the senior people are even more blind than the juniors. So when the blind shall lead the blind, both shall fall into the ditch. But the only difference between this biblical saying is, when the blind shall lead the blind, the patient shall fall into the ditch. not us, not the blind themselves. So the point again is a very important question. I urge you guys now onwards to spread this message the way the apostles did. Do not use the word valgus and varus for joint line related descriptions, whether it be a cut, etc. Use the word apex up, neutral, apex down, whenever you use the joint line related, and use the word varus and valgus only when you are referring to the constitutional alignment of the limb, which means the alignment of the limb as a whole, which will include the contribution made by the femoral bowing or a tibial shaft bowing. Because depending upon your femoral and tibial shaft contributions, and also the contribution of the bone loss that will occur here during a pathologically worn out knee, you might have a constitutionally varus, neutral or valgus knee with a joint line which is independent of that. It could be apex up, apex down, neutral. Now if you use valgus cut here, if you use the word valgus for your joint line inclination, but at the same moment you are seeing the limb in varus, the brain will get confused कि आप तो बोल रहे हो जॉइंट लाइन वेलगस में है, लेकिन मैं देख रहा हूं कि लिम्ब तो वेरस में है. और ये जो कंफ्यूजन होता है, जो अभी तक होता चला आया था, एंड आई एम गोइंग टू डिबेट against Sam McDessie himself. Sam McDessie is on the other side in August later this year at the APES conference, and I'll have to make myself, my adrenaline is flowing because I'm going to talk to the man himself, about this. But it's all the more exhilarating for me. So मैं आप लोग सबको भी काम पे लगा देने वाला हूँ लिटरेचर सर्च वगैरह करने में, बट ऑलरेडी है ही मेरा दिमाग में तो, बट करूँगा. सो again, to answer your question, the word used, go back. See here, this is the words, these are taken from historical. This lecture was made 15 years back. Femoral locating device is set and locked to yield the appropriate valgus angle for the distal femoral cut. See that valgus angle. This is where the mistake is. I should from henceforth use to yield the appropriate joint line inclination, whether it be apex up, neutral or apex down. ये valgus angle लिखने से क्या होता है, आपको ऐसा ही लगता है कि इसके बाद limb will be in valgus. Actually, in a mechanical axis approach, the final orientation of the constitutional has to be at 90 degrees to the mechanical axis. So फिर valgus शब्द कहाँ रहता है? It is valgus only if you talk about it in relationship to the anatomical axis. But the moment your mind migrates from the anatomical to the mechanical, which is what the real biomechanics discussions is all about, it is no more valgus. It is at 90 degree, it's in neutral. So once you understand this, you have gone to the core of understanding this entire hot area of discussion about axes and alignments and all that. Are you guys clear? Good. Once you have done that, you put your distal femoral cutting block on top of it, and then you take your distal cut from here. And the distal cut, again, the distal femoral cutting block has got this offering of how much thick you want to have the cut, and depending upon the system you are using, most systems end up giving you a 9 millimeter thickness of the femoral component. The distal thickness of the artificial femoral component, the metallic component, is 9 mm. So in theory you are supposed to take away at least roughly about that much, 9. So when you put it on 9, here this reading on 9, and then you take the appropriate slot, it would have written, some system will say this is the standard slot. In PFC sigma, this is the standard slot, and then you also have these holes which allow you another 2 millimeter up and down. This is all common. Once you understand the concept, any system you just have to familiarize yourself. कोई बोलेगा कि हमारा बीच वाला है, that is the standard, and ऊपर नीचे आपके पास वो है. Okay, so then you take your cut next, and that is your real life. As you can see, it is all loaded and now take your next. And as you can see here, this 2 plus minus 2, 4, 0, these are all different combinations that this piece of metal offers you in terms of fine tuning the final depth of your cut. Samjhan pade?
Yeah, I wanted to ask, what are the situations when you would need to use the plus 2 minus 2?
Very good, perfect question. Remember that this facility is available. When we discuss fixed flexion deformities, lax knees, that is when I will tell you when this all will be very useful. So now, you have cut it, as it says you can adjust this here and there. Next, just before cutting with an angel wing, you are making sure, what am I checking here? That by mistake my cut is not, for whatever reasons of mistake that might have happened, it is not so much that I am getting into the condyles, into the epicondyles.
When can it happen that the angel wing might be so deep?
The angel wing, but I mean the angel wing shows that it is, your cut is going to be so deep. Well, it can happen if, for example, your go back to the assembly, go back a couple of slides. Let's see here, instead of 9, you think you have put it on 9, but it has slipped and you are sitting on 11, 12, something like that. Or there is a play has happened, or there is a bone wear out so much, your distal bone, femoral bone has worn itself out so much that it is already more than 9. Go back one more step, go back here, hold this. See, when you are, the depth is going to be decided by where this outrigger is sitting. Now in theory, just imagine that the bone loss is up to here, and now you have put it on top of that, then obviously your cutting block is going to cut it from here actually. I am exaggerating to make my point. So you have to be sensitive to that part, Next please. So that brings me to a simple question. What is the position in terms of the distance of your medial epicondyle as compared from the joint line? What is the distance?
2.5
Centimeters.
is medial and 3.5 is that.
Perfect. So that's a very important parameter when we will talk something about the significance of joint line elevation, joint line positioning. It's a separate lecture in itself. So if your medial is escaping, then obviously your lateral is going to escape. It is 1 centimeter more. Next. Now the cuts are being taken. Next. Just small practical tips. Those photographs are meant to actually expand on this. That no matter of theoretical knowledge can compensate the artisan's ability that you need to have as orthopedic surgeons, which means you need to know your saws and drills as individual personalities. Each saw, each piece of equipment has its own personality. कोई साला ढीला होगा, कोई बहुत ज़्यादा होगा, कोई वाइब्रेट करता होगा, किसमें प्ले होगा. आपको वो जैसे कारपेंटर, अगर आप राजस्थानी कारपेंटर को, इफ़ यू सी अ राजस्थानी कारपेंटर एट वर्क, he will know those basic instruments that he has, they are part of his body extensions, and that is why he is able to do this joinery the way he does, without any navigation or robotics, and again, in sometimes much more tough material than what we have. We have only one consistency of, and that's bone. यहाँ तो प्लाईवुड भी हो सकता है, विनियर भी हो सकता है, लेमिनेट भी हो सकता है, शीशम का लकड़ा हो सकता है, साग का हो सकता है, and yet they are able to do it, So here we go. So you have taken your cut.
In an ideal situation, you would say that the blade has to go straight down to take the distal femoral cut. But if there is a play in that system or the jig, is it safer to go with the blade touching the upper edge or blade touching the lower edge?
Many times when your set has been used again and again and again, the standard slot would have expanded as compared to the alternative slots. And end of the day, it will be half a millimeter, at the most half or 1 millimeter. So it's not going to be dramatic in that sense. Anything more than that, that instrument would have to be discarded. That piece of block would have to be discarded. This is half to 1 millimeter. And again, that's where you guys need to understand that when you are in your formative years, you earlier today in the morning, Asha and I had a chance to just banter about some subject knowledge, and I was telling him that one of the problems with residency training is that because you are such an impressionable mind at that time, later on unfortunately becomes exactly the opposite. But in those days, you are so impressionable and eager to learn, and you put your teachers on a pedestal. So you end up thinking that whatever you have heard is gospel truth. And there's a difference between truth and gospel truth. There's a reason why the word gospel is attached sometimes to emphasize. Gospel is God's word. Truth is anything truthful. I mean, that glass cup can break if it falls on the ground. That's truth. You will accept it. But if you are a true believer, and if someone has told you that the gospel truth is that if Acharya ji drops it, it will never break, then you will actually believe the gospel truth more than the truth that otherwise would have offered you as part of your common sense, you know. So, unfortunately, the impressionable mind takes the teacher's word as a gospel truth instead of just truth, you know. तो gospel truth में ये हो जाता है कि 1 mm 0.5 mm वो जो बोला वही पत्थर की लकीर बन गई. So you will have to learn to unravel that to the extent, not forget about everything that day, but unravel it to the point where you also take, oh okay, so it's not all that important, right? 1 mm or 3 mm, or in this context, that 1 mm 2 mm in an ophthalmic context can be the difference between blindness and not blindness, but in this context, you know. So that's a very important part of becoming a good learner. So as Kshitij said, you take the lower part, and there are so many small nuances, and I'm going to stop the lecture today just at distal cut. See, amazing, how amazing it is. We are struggling 45 minutes to 1 hour lecture only on one cut, which on table you will end up doing within 8 seconds. 8 seconds, and no application of mind, obviously so. Although once you have understood and internalized this, that application of mind is happening, but it is happening in a flash, like so, you know. So when you are doing your bone cut, whether it be the distal femoral or proximal, you, as I told you, you need to know your, so when you have free moments, when the surgery is over, there is still some battery power left in that saw, pick it up, and like मैं तमने demonstration भी आप्યું છે, turn it into a musical instrument and think of yourself as a master musician. So you know, ये as a conscious effort try to see whether you are able to control that. In other words, what you are doing is your finger is controlling the trigger with that finesse, you know. और वो जब आपके हाथ में आ जाएगी तो फिर आप जब कर रहे हो तो यू विल नॉट बी स्ट्रगलिंग कि मैं क्या काट रहा हूँ, वो देखने में इधर ऐसा ऊपर कर दिया है सॉ आपने, तो यू आर डिपिंग द सॉ इनटू द बोन. और सॉ लेते समय कौन सा सॉ है, ब्लेड को देखा, ब्लेड की एज पर अंदर से उसका टीथ अंदर कर्व हो चुका है, एक्चुअली दैट इज़ वेयर द कटिंग स्टार्ट्स फ्रॉम. सो इसमें तो मेरी मेहनत ज़्यादा होने वाली है, ये बोन सला डेंस है, एकदम हार्ड आइवरी बोन है. तो मैं पहले से अगर ऐसा हो, ऑडियंस कोई देख रहा है, किसी को मैं सिखा रहा हूँ, थका हुआ हूँ, तो नर्स को पहले ही बोल दिया कि ओ भाई ओपन अप अ कम्प्लीटली फ्रेश न्यू ब्लेड, आई डोंट वांट टू स्ट्रगल हियर, और चेंज द सॉ, ये सॉ मेरे को काम नहीं देगा. ये सब दीज आर द इवेंचुअली इट ऑल बॉइल्स डाउन टू दीज स्मॉल थिंग्स, यू नो, फॉर यू टू गेट थ्रू अ सर्जरी कॉम्पिटेंटली एंड विदाउट गेटिंग मेंटली एग्जॉस्टेड, यू नो. बट शुरुआत में हम लोग ने किए हैं यार, साले पैसे ही नहीं थे, तो आप इधर कर रहे हो, इतनी सारी नर्सें, इतनी सारी, माई सेल्फ, माई वाइफ and 1 nurse. We were only 3 people in a joint replacement for years. It was I didn't have the luxury. I had one registrar whom I trained, you know, where he became independent enough in those days. And then of course God sent Rao. So but बाकी ये सब हम खुद करते थे. you know. So, but so you guys should build upon this, you know, the modern science. हमारे पास कौन teacher नहीं थे? We were the pioneers of this thing. There's nobody. Those books that you see there, I've thumbed through them so many times. Revision ની આખી book में વાંચી નાખી છે બધું. Even after getting into practice, I already had 2 sons by then. You know, and I didn't have the sort of financial. We were happy eating, खाते पीते सब सुखी घर के थे, but nothing. You know, ऐसे कार लेनी हो तो it was a big event. आज के कॉन्टेक्स्ट में ये सब थोड़ा कम हो गया है एट ऑल लेवल्स. आई एम नॉट टॉकिंग अबाउट द मोदी फैमिली, आई एम टॉकिंग अबाउट ऑल ऑफ यू गाइस, यू नो, मोस्ट ऑफ यू. एनीवे, सो द पॉइंट इज this is your distal cut, and once you do your distal cut, next please, we will stop at the extension gap. So this is, the knee is now placed in the extension position and the gap is assessed, and you will see, as I told you, it's all about creating a rectangular gap, which the entire debate about the axis alignment, kinematic, ye wo, it's about this gap being like this or like that or like that, or a combination of all that. That is the all this intense complex debate about. बाकी जो underlying principle है extension में rectangular gap, which basically stretches out the ligament and brings adequate tension. Now what is adequate can be another area of discussion. कि what you see on the table, even if you have sensors put into soft tissue, some sensors which can generate a tension figure to it, you know, but that is in an anesthetized patient, and the tension you are generating is either by virtue of your muscle power or by the tension you generate by stuffing it with hard metallic object. But in real life, that yesterday, that lady like this, she's a woolly mammoth walking like that, you know, and is there any chance with even the biceps of a Vipin or a Mahesh that you can generate the sort of pressure that that body is generating on those ligaments? Zero possibility. So what the hell are you talking about? Whether with navigation or robotics or you know, electronic sensors registering some numerical values to this in an anesthetized patient, where the only way you are generating tension is one by either using your muscle power, or the other is you put some stuff in it, but that those two entities are nothing to do with the actual tensions that pressures or pulls that will be generated when the woolly mammoth walks, you know. So so that's how it is. So appropriate soft tissue release is done, and so you have now reached the one half of your surgical action, you know, which means creating your extension gap by doing your tibial cut and distal femur cut. Wonderful. The next lecture will be about anterior and posterior cut and chamfer TKR, and that will be the essence of TKR, but that in the next lecture. Great. Have a good day, gentlemen.